Welcome, everyone. So thanks for joining bright and early for some of you or late afternoon for others. This is the COR-NTD pre-meeting on integration in action, examples of integration in NTDs. As you probably saw, this presentation, this session is filled with lots of different presentations, but kind of the unifying theme is integration. And so we have a shared understanding when we talk about integrated data systems, we're referring to data systems that derive all or part of the data they contain directly from another source. So data system integration allows us to do more with the data that exists and avoid the various pitfalls that duplication of data in unlinked systems can cause. And we'll get into some of those pitfalls throughout the presentation. Okay, so the session outline. Today's webinar is going to be presented in really 3 parts with a 10-minute break in between part 1 and 2. During the break, there's going to be kind of a looping presentation by the Ascend Learning and Innovation Fund, and representatives for the fund will be available to answer any questions. I mean, feel free to take your normal break, but if you come back early, hopefully you can catch that presentation. And if you have any questions, you can ask them. Part 1 is going to be focused on the ESPEN portal and the integration with tropical data and the Get 2020 database, as well as integration with IHME and other systems to be able to pull data into one resource. There will also be a demonstration on how to build an interactive dashboard connecting to the ESPEN API. I think this could be a really interesting presentation for those who either are not familiar with the ESPEN portal or are not familiar with the data that it contains, or how to use an API to build your own data products. So I hope you'll find this to be a very interesting session. As we move into part 2, we'll shift from global systems to national systems. There we're going to talk about a pilot in Kenya by the Ascend group that is trying to improve inventory management through an SMS system. We will also talk a little bit about some of the challenges of moving from a disease vertical program into an integrated program. And we'll talk specifically about TT surgery. And finally, we'll wrap up a little bit about, yes, we can build these systems, but they're only useful if they have impact. So what evidence of impact of making open data available? And we'll have a talk about the impact of the NTD deliver system. And then we'll finish with just a fun retro session where people will be assigned into groups, and we'll all get an opportunity to contribute our own ideas about these 4 thematic groups that deal with some of the challenges and opportunities of integration. Okay, so hopefully that'll be an interesting day's session. Okay. So today's outline, as we discussed, was that it's going to be broken into 3 parts with a 10-minute break in the middle. The first session is going to be on these global systems, and specifically about the ESPEN portal and how it aggregates data from multiple platforms. And we're going to have 3 topics, but it's going to result in 5 speakers. One of those speakers is going to be a video that will walk you through using the system. Using the API to connect to Power BI. And maybe now we can transition over and have Jorge lead us out and kind of give us an overview of what the ESPEN NTD portal is and how it's an example of integrated data systems.
Yeah, first of all, well, good morning or good afternoon to everyone. First of all, I want to thank the organizers for inviting me to make a short presentation of the ESPEN data portal. So then I'm talking as, ESPEN data analyst, but I'm a member of, the ESPEN data teams, and I will be talking on behalf of the rest of my colleagues, who probably most of you know are Honorat Zure, who is the ESPEN data managers, and my colleagues Elia Muhima and Diese Jumba, who are responsible for maintaining and supporting ESPEN Collect tool. So then today I'm going to talk a little bit about the ESPEN portal, and particularly how all the data coming from the joint application package is integrated within the system, and also how we are connecting with other services such as the tropical data or the JET 2024 trachoma data. So then, Alex, the polls has been very helpful to understand what the audience knows about the ESPEN data portals. Yeah, probably, as I've seen, most of you are familiar with the interface of the ESPEN website. So the important things and what everyone needs to understand is, the ESPEN data portal is more than a data repository. So then is an NTD data platform who not only have data, but also have other resources, to make, the data reporting system from countries and from partners, much easier. So then I'm trying just to organize, the main features available at the ESPEN data portal, like in two big blocks. One of the blocks, is actually related to this big data repository that we have developed around, the joint application package and the TMF. Basically, from this reporting system that WHO has created, so then we are extracting data related to the endemicity and also related to the treatment activities that countries are developing. So then we are organizing the data at two levels: community level and implementation unit level. So then with this data, so then we are providing a wealth of thematic maps, basically around these two big, outcomes: endemicity and treatment history. So then there is another block, which is very important and probably is less known by the audience, which is basically a suite of tools and features that are intended to, for the countries to report their epidemiological data. For example, the ESPEN Collect tool, so which is intended to facilitate, how the data is collected in the field and how this is, stored, saved, and processed within the system. So then we have also a feature to make much easier to the countries to submit the joint application package form. This is the joint application package upload tool, which basically guide countries and partners through the validation process of the joint application package form. And we have, plenty more resources, such as, the cartography, the base map for implementation units that we are using to generate the maps. So then we have a search tool to allow the users to find specific maps and many other features. We also have, a section for news and for official documents, such as the mastering plans that countries are submitting. I've seen that some of you are not very familiar with the joint application package and the TMF form. But basically, these are WHO forms that are intended to collect information on all the treatment activities that countries are developing, specifically the GRF, which is intended to collect information concerning, the treatment activities. So we have the APRF, which is intended to collect information on epidemiological surveys, entomological assessment. So then we also have another form which basically collect insights on the annual working plans that countries have set for this year. And we also have another form, which the countries are using to make the medicine requests for next year activities. In addition to this, so then there are plenty other resources and data that countries can submit, such as, the treatment coverage surveys and so on. This slide basically shows like a very, a summary of the data processing workflow and how all, this data is integrating within the ESPEN data system. As Alex explained in his presentation, most of the countries and most of the NTD programs are submitting the joint application package and the TMF using Excel, the Excel spreadsheet forms that WHO has developed, and they are submitting this via email. But we are having more countries using this new JAP upload tool because definitely makes much easier for them just to submit the joint application package and basically follow up all the validation process. So when the joint application package is submitting and has been validated by the different parties, WHO, the country programs, so then this data is imported using a tool that we have developed. So then we have a tool that basically is extracting the data from the joint application package form and imported into a SQL database. So this database is hosted in the Afro server, but we are generating a backup in one of, in the server of our partner standard code. Basically because within the Afro server, we have many restrictions to allow third parties to get access to the database. So then the database is back up in a regular basis when new data is entering into the system. And then, well, as you can see, so through the ESPEN Collect tool, epidemiological survey data is also collected, and this is also imported automatically or entering automatically in the ESPEN database. So then we are calling this database as transactional database. Afterwards, so through a suite of scripts that has been developed using the R software. So then we are processing and extracting and organizing and cleaning up the data from this transactional database and generating summary tables, which basically compile the most important indicators for endemicity and for treatment. So then these are called the analytical tables, which are saved in a separate SQL database, which is the so-called ESPEN NTD analytical database. So then within this analytical database, so then this is the point where we are connecting with tropical data and JET 2020 DB, and all the trachoma outcomes are entering and importing the analytical data. So then we'll have later Anna talking about this integration. On the other side, we are also using some useful resources provided by the Institute for Health Metrics and Evaluation, which measures of water and sanitation. So then Rachel will talk from London School, will be talking later about this data set. So what we are doing is generating summaries of these water and sanitation indicators at implementation unit level, and this is integrated into the analytical table, data set. So then afterwards, through a suite of APIs, API stands for Application Programming Interface. So basically, so then we are querying these analytical tables and feeding the so many features and resources that we have under the ESPEN Data Portal. So then with this API, we are connecting with the ESPEN Map Builder that has been developed by another partner, Manta Ray Media, which basically allow us to automatically generate the maps that you can see now in the ESPEN Data Portal. As I'm going to explain now, this API platform is really crucial for this integration of data, because through this API, we allow, third parties just to consume some of the resources that we have developed and we have in the ESPEN Data repository. Very quickly, this is another representation of the same data processing workflow, but basically is the same, explanation. So the important bit, and I think we'll have colleagues today just talking about the application programming interfaces, the APIs that we have at the ESPEN Data Portal. So as I explained before, so these API are intended just to query, all the information that are available within the analytical table database. So then the important bit here is that the APIs are available, are public available and can be accessed by third parties. So then we only ask, for those that want to use this API to register in the system. So then they automatically get a key, which allow them just to basically access to and use this API. Thank you for attending this pre-COR-NTD session. And yes, back to you, Alex.
Great, thanks, Jorge. So before we have any questions, we're going to go ahead and pass it on to Anna. That's going to talk about the integration of tropical data in GET 2020 that Jorge mentioned a number of times. So let me go ahead and pass it on to Anna.
Hello, everyone. My name is Anna Bakhtiari. I'm lead systems analyst for tropical data and the International Trachoma Initiative. And today I'll be presenting on the data systems integrations implemented by Tropical Data and ITI in support of health ministries, and many of which were in collaboration with ESPEN. So first, I'll provide a brief overview of the Tropical Data Service, then talk through some of the system linkages we've implemented, and then I'll talk briefly about the GET 2020 database and some relevant outputs from that database. So first, Tropical Data is a global initiative to support health ministries collect high quality, standardized prevalence data on neglected tropical diseases with quality assurance and quality control at every step. Surveys are an essential step on the path to elimination, collecting data to both inform program planning and to validate the impact of interventions. Tropical Data supports the survey process, or the full survey process, excuse me, from planning and protocol development through to data management and analysis. It helps ensure that surveys are conducted using WHO-approved methodologies, that outputs are of the highest quality, and that health ministries have full ownership of their data. Tropical Data is a partnership between health ministries and the partners you see here: London School of Hygiene and Tropical Medicine, ITI, RTI, Sightsavers, and WHO. It's a team I feel very privileged to work with. So to give you an idea of the magnitude of the data, I'd first like to touch on the project impact thus far. So since the project began in February 2016, Tropical Data has supported trachoma surveys in nearly 2,000 evaluation units, examining over 6 million people in 43 countries across 5 WHO regions. The project supports 4 trachoma survey types. First, baseline surveys to determine the need for interventions, impact surveys to determine if these interventions have achieved the elimination threshold or if further interventions are needed, surveillance surveys to show that reductions in prevalence have been sustained, and lastly, trachomatis trichiasis, or TT-only surveys that are recommended in certain epidemiological contexts. The results of these surveys translate directly into programmatic decision-making, including confirmation that MDA should be started or continued, that MDA is not needed, that MDA can be stopped, or most excitingly, that trachoma is no longer a public health problem. So to support health ministries with sharing and using these data, we've worked to integrate Tropical Data with a few other systems, some of which Jorge's already mentioned. So first, we give health ministries the option to automatically share a subset of the fully approved district level point prevalence results with the joint ITI WHO GET 2020 database. As I'll discuss in more detail shortly, the data housed in this database are used to pre-populate both the Zithromax applications and the Trachoma Elimination Monitoring Form, or TEMF, that are sent out to health ministries each year. This integration with GET 2020 results in very high survey reporting rates on the TEMF and enables rapid programmatic decision-making as surveys are completed in the field. We also ask health ministries to opt in to the use of district-level prevalence category data to update 2 open access resources that Jorge has already mentioned, the Trachoma Atlas and the ESPEN Portal. This integration ensures that both sources reflect the same data, which is really important. And then this year, in collaboration with the Federal Ministry of Health in Ethiopia, and with the support of their in-country partners and our developer, Adam Wilson, we work to establish an API to provide real-time access to an expanded analysis result with the NTD DHIS2 database. This integration ensures that the federal ministry, as well as any subnational NTD database users, have access to the Trachoma survey results without the need for manual export and import of those data from the Tropical Data website. So the Get 2020 database that I mentioned on the previous slide is a joint ITI-WHO database. It's maintained by my ITI colleague, Kristen Reneker, and many thanks to her for her help with the content on these next few slides. So this database provides a repository for permanent secure storage of subnational level data on the prevalence of trachoma and the history of interventions against it. The three main tables that house the majority of the data are distributions, programs, and surveys. The distributions table contains district level data on MDAs by program year. The programs table contains district level data on Zithromax requests. And lastly, the surveys table contains broadly the survey history for each district in the database. So for the sources of these data, at the top of your screen, you'll see an example of the trachoma elimination monitoring form. Distributions data are collected through this form, and they're pre-populated and sent out to health ministries in January of each year so that they can report on safe interventions for the previous year. In the middle, you see an example of a Zithromax application. These are pre-populated as an additional tab within the TEMF workbook for health ministries that are applying for Zithromax for the subsequent year. And then for survey data, you'll notice that I highlighted the survey data section on both of these forms. The results of the tropical data surveys that are automatically shared with Get 2020 are pre-populated in these two sections before they are sent out to countries. And lastly, so surveys data are mostly, or they come in on a rolling basis as surveys are completed. Most surveys are now supported by tropical data, but for any non-tropical data results, they're typically shared via survey reports that are then entered manually into the database. To be more precise on this split, of the roughly 2,600 district level survey records entered into Get 2020 database from the start of 2016 through to today, 92% of these were sourced from tropical data. And since 2016, this percentage has increased with each year, and it was 99% in both 2019 and 2020. So in addition to supporting various annual global reports, like the WER and ICTC's Accelerating Towards 2020 Appendix, the Get 2020 database is also the source used to update two open access resources, the Trachoma Atlas and the ESPEN Portal. So the Trachoma Atlas is developed and maintained by ITI, and it provides publicly accessible maps of trachoma prevalence categories and annual MDA at the district level. Jorge has already covered the ESPEN Portal, so here I'll just mention the data that are shared from Get 2020 to ESPEN. So Kristen at ITI prepares once yearly exports and then shares them with the ESPEN team. These exports include both survey data and treatment data. So the survey data shared are the TF category, TT category, survey type, and survey year. This includes both tropical data and non-tropical data surveys. And the treatment data include a binary did MDA occur variable by district and year of MDA. This automatic sharing reduces the burden on health ministries to manually report these data to multiple systems and also enables us to provide a global picture of trachoma prevalence. So I've already mentioned some of the benefits of integration on other slides. So just to summarize here, most importantly, integrating data systems reduces the burden on health ministries to report to different databases. It also results in very high reporting rates for surveys on the TEMF. It enables rapid programmatic decision-making by health ministries, their implementing partners, and donors. It allows for pre-population of reporting forms, minimizing the need for health ministries to manually enter these data, and in turn, increasing data accuracy. It ensures that data are consistent across different systems, for example, the Trachoma Atlas and the ESPEN Portal. And lastly, it facilitates data sharing and use. So that's all I have today. Thank you for this opportunity to share about some of the work being done to integrate our trachoma data systems.
Great, thanks, Anna. Before I pass it on to Leah and Rachel to talk a little bit about the WASH modeling data, I think it's important to sort of understand the difference between these two types of data. The data that Anna explained and the data that Jorge explained are both on standardized forms. So it's fairly easy to aggregate data coming from multiple countries across multiple years because there's a standardized reporting form. For WASH, because it's not included on these forms, and because there isn't a similar form for WASH, makes it a little bit more challenging. So Rachel will talk about using modeling data to be able to kind of bridge that gap of standardized reporting. And Leah will talk a little bit about building a national level resource where possible to integrate NTD and WASH data into some national system. So Leah, I'll pass it over to you to take it from there.
Thanks, Alex, and good morning, good afternoon, everyone. I'm just gonna share my screen. My name is Leah Wolgemuth, and I serve as the technical advisor for WASH and behavior change for Sightsavers. So as Alex mentioned, while I think we all know that WASH data is important in the control and elimination of NTDs, how we kind of get that information in line with NTDs has proven a bit tricky. So just as a bit of background, why do we want WASH and NTD data together, and why is their integration important? So again, I think over the past 5 years, there's been a big kind of shift in highlighting the importance of WASH within NTDs, and WHO WASH and NTD strategy has really highlighted the need for coordination and collaboration between the two sectors. So with that basic understanding, we have then kind of identified if we could have WASH data looking at coverage and access in the same database or in conjunction with NTD data, it can help for a few different reasons, which I've listed out on the screen. So one would be targeting of resources. So again, if we can identify areas, districts or regions that have very high NTD prevalence and very low access to WASH or coverage of WASH services, then this gives us a direction in which we might want to target our resources in hopes that increasing the WASH access and coverage will also improve our NTD targets. Again, you can look at integration amongst diseases, so especially around schisto, SDH, and trachoma. Those are often the diseases we think about in most kind of relation to WASH, and looking at if there's high burden of all those diseases in one area and also low WASH. That's another good area to look at. It can also flag areas where we think joint WASH and NTD interventions would do best, and then it helps us with efficiency through coordination. So just again, having the data in one place is really useful, and as I think we can all probably agree on this call that it's not as easy as it seemed. I know, in Ethiopia, every sector, every organization spells every warrior differently. So there's many challenges with that, but just to give you kind of a bit of a background and show you where we've gotten thus far before I hand over to Rachel. So again, this is just another way, a kind of 2x2 table of looking at how we kind of see WASH and NTDs together in ways in which we can group them to help prioritize. So if we're starting in the top left, we would identify any area with high NTD endemicity and low WASH coverage as kind of a target area. Then moving to the right, if an area has kind of high WASH coverage and high NTD endemicity, maybe that's an area where we can better do some joint planning and try to capitalize on the availability of services. Here we have a low, bottom left now, a low WASH coverage and low NTD endemicity. While it's great that we see low NTD endemicity, perhaps we need some WASH advocacy needed to make sure that the endemicity remains low. And then in the bottom right, we have our desired scenario in a very perfect world of high WASH coverage and low NTD endemicity. So again, another kind of way of framing of how we can look at the combination of WASH and NTD data. So with that as a bit of background, I just wanted to highlight some work that we've done on the Accelerate program and kind of how we thought to bring these two systems together. So We did a kind of WASH data and HMIS assessment across all of the countries shown on the map to really understand what are the NTD data systems. This is in conjunction with some work that Alex led, and then understanding what are the WASH systems. So I think we kind of came to the conclusion that we don't want to build anything new, but we want to identify where there are existing databases, how we can best integrate those. So once we kind of got the data back on from those assessments, we really identified 3 potential opportunities that could come out of this. So here we have model 1, which is where there's an existing NTD database, and perhaps we can add WASH into the NTD database. This is something that we have successfully done in Ethiopia. So that's one example of that. And again, there's some challenges, but it's great to see that we now have the NTD DHIS2 database in Ethiopia showcasing WASH coverage. The second option that we identified was to kind of the reverse, adding NTD data into the WASH database. So in some countries, either there was not an existing NTD database, there was an Excel sheet or something that maybe was not conducive to integration, whereas there is a robust WASH database that could be used. So here we would add NTD data into the WASH database. And obviously these models make it look quite simple, but I think this audience knows that there's a lot of elements that go into kind of integrating these databases, and we can discuss probably challenges on a whole other conversation. And then finally, we recognize, in some cases that there are not either WASH or NTD databases that we can integrate, or countries maybe were not open to that idea. And this is where conversations with ESPEN began around how we could include WASH data on the ESPEN portal. But again, as Alex highlighted, challenges around a lack of standardized reporting for WASH at this stage. So we're starting with model data, which and JMP data, which Rachel will share, and hopefully, that may evolve over time, and we may look to import standardized data as well. So I just to kind of show you all what the results of the survey or the assessment showed, and kind of which countries had the different options. So, you see some countries such as, let's say, Kenya and Tanzania and Zimbabwe, where they had both WASH and NTD databases available, and then it was a matter of conversations in country whereas to what made the most sense. Just to highlight here, in Tanzania, we're actually adding NTD data into the WASH system. In Zimbabwe, it's still up in the air, and conversations are kind of being argued for both directions. And in Kenya, we're hoping with working alongside Ascend to add WASH data into the NTD database. Those highlights are just kind of priority countries for Accelerate, where this integration is moving forward quickly. So just kind of in summary and wrapping up before I hand over to Rachel, I just wanted to highlight kind of how some of this data has already been used, and also to note we're really at the beginning. I think there's a lot of excitement around with the WASH data being now added to the ESPEN portal and in progress, that there's a lot more use to be had. But for right now, we've seen the data kind of used at advocacy meetings. There's been some WASH and NTD coordination launch events in Ethiopia in which this data has proven very useful. We also have seen this data used with WASH and NTD task forces. I should highlight, this specifically says task forces, but that also includes technical working groups and other, NTD groups where maybe the WASH sector is present, and WASH group for the NTD sector is present, and vice versa. So just any kind of group or joint task force in which those two sectors are together. And as I've highlighted throughout, we've identified the models in all the countries on the previous slide, but the work is really underway in Ethiopia, Nigeria, Kenya, Tanzania, and Zimbabwe. So that's just a bit of background in some of the work that we've done at Sightsavers with our partners, and then also I will hand over to Rachel to share the updates on the ESPEN portal.
So I'm going to continue this story and look at actually how the WASH data has been incorporated within the ESPEN data portal. And I'm from the London School. My name's Rachel, but I'm presenting on behalf of the ESPEN Portal Partnership, which includes, led by ESPEN, and includes a number of technical support partners that you can see listed here on the left. I think this statement's quite helpful to sort of frame the way that I've chosen to present this story, and that is that the goal of data integration is to combine disparate sets of data and produce meaningful information with that data. And I'm going to focus on those two aspects there, combining the data and then actually how do we use that to produce meaningful outputs that can be used to help drive decision making. As I think Leah demonstrated really effectively, the challenge with WASH isn't that we don't have any WASH data. There are lots of really good examples of high quality WASH data available through national databases or collected during representative population level surveys, including NTD surveys, so trachoma surveys typically collect WASH data. So there is a lot of WASH data, but it's not necessarily in a generalized format. The JMP, the Joint Monitoring Programme, is mandated to produce WASH data globally, and they have an excellent database which includes national data sets, and you can query it and see data, really useful data at a national level. So I'm showing an example here from their website. If you go to their website, you can query a country, and straight away you can go and interrogate it. You can look at different indicators. You can look at access between urban and rural areas. You can look at changing access over time. What you can't see, though, is sub-national level data. And for NTD decision making, we want standardized sub-national level data. So this is the challenge we're up against at the moment. The data at the right spatial scale is in lots of different formats. It's challenging to bring into a global resource in a straightforward way. The nice, robust, standardized data sets are available at a national level only. Luckily, very recently, so only last month, the local burden of disease WASH collaborators group based at the Institute of Health Metrics and Evaluation published high resolution maps. So this is very fine spatial scale predictive maps that incorporate all the same data that is used by the JMP, but using a slightly different framework to model it, and ending up with very high resolution maps of coverage of access to water and access to sanitation indicators. And they published this and made these rasters available. So now we have data available at subnational scales with standardized outcomes generated using robust methods, but it's still not at the right spatial scale for NTD decision making because it's continuous. And so this is what ESPEN have done. They've now assembled this data, aggregated it at an implementation unit level, and made these maps available and the data available through the ESPEN portal. So if you are now to go and visit the portal, you'll notice that there's a new tab there under all the country pages, and that is WASH. And through those pages, you can access WASH maps. So that's separately for each of the water and sanitation indicators. You can access those over time for each of the for every country. So far, so good. This is really good. We've now got WASH data within the same location as NTD data. But what we really want to be doing is thinking about how best to combine these two data sets to make a really useful resource for decision making without having to put one next to the other. And this is what we're doing now. And I've nicked this nice graphic here from Leah's slide just to show the two areas we want to be thinking about is how do we align NTD endemicity with WASH coverage within this framework. And there's a few questions here, really. First off, we need to be thinking about when we're looking at defining NTD endemicity within a useful visualization using our data, what do we really mean? Do we want all the diseases on one map? Is it more useful to have them side by side? Are we interested in differing levels of endemicity? And likewise, when we consider WASH, what do we mean by WASH? Are we interested in access to improved water? Are we interested in open defecation? Do we want to look at them both at the same time? The other important metric to think about with WASH, with NTDs, it's quite straightforward. We're very familiar with our levels of endemicity. And so we have our threshold, so we can classify districts based on a given level of endemicity. With WASH, it's slightly less straightforward. There aren't clear thresholds. We're looking for universal access. So how do we choose to classify areas as high and low? And this is the issue that we're grappling with at the moment within making this data available through the portal. And so I'm showing you here a prototype for how we've chosen to present this. These aren't yet available online, but I'm going to be reaching out to a number of you that are on this call to ask for further feedback on whether this is the right way to be presenting this data before they're made online very soon. And so you can see in this example here, we've had to present the worms side by side. So we have STH maps on one side and Schisto on the other. And each implementation unit is now classified based on the endemicity status, and then whether they are above or below the national median level of access to improved water and to improved sanitation. So if I put this side by side now with Leia's useful 2x2 table, you can see straight away from this overlay, we can very quickly identify those areas that have been classified as high priority. That is, they have high prevalence of, in this case, schisto, and they have low access to improved water and low access to improved sanitation. And similarly, we can identify other areas with joint planning opportunities which have high levels of NTDs, but perhaps better access to, in this case, to water. So that's my quick whistle-stop tour. As I say, I'm presenting on behalf of the ESPEN Data Portal. If you have questions on how these are all integrated and brought together, then do put them to me, but also any one of my partners would be able to support you on that. Thank you.
Great, thanks, Rachel. So before we go into a demo of an example of using the ESPEN API to build a data product, and for that, we have a video that you can watch that'll walk you through it. We'll go ahead and push on to the video that shows an example of how an external partner can use the ESPEN API to build a data product using ESPEN data.
In this short video, I will demonstrate how to build a basic but dynamic dashboard in Power BI using LF forecast data sourced from the ESPEN portal via the ESPEN API. We're going to start our journey here on the ESPEN API website. So an API is an application programming interface, and what this really means is that it is an intermediary that allows two software applications to talk to each other. So it's a messenger really. In this case, it delivers a request for data from the ESPEN portal and delivers the response to Power BI. Now the ESPEN API is collectively composed of a series of different APIs, depending on what data you want to access from the ESPEN portal. Now to build our dashboard in Power BI, we want to use the ESPEN Data API. However, before we can do this, we first need to request an API key. And this is a passcode that allows ESPEN to track API data use. And that's really easy to do this. You just click here, request API key, and submit your email, your name, and your organization. Very shortly, they should get back to you with your key. Now the ESPEN Data API has its own subsite. And here, there was a lot of really great information that will explain how to build your API call. So that is how to outline your parameters for what data you wish to bring into Power BI. A note of caution here, though, is to reduce your parameters as far as possible, as it could otherwise be a very slow process, or it may time out entirely. And your call will probably look something a little like this. So once you have set out your API call, then we are then ready to use it to bring data into Power BI. So we're starting here with a blank Power BI workspace. So we first need to get our data. So to use our, we just click web, paste it in here. Now it's just going to take a few quick seconds to retrieve the data from the ESPEN portal. But before we can do anything and build any visualizations, we first need to prep the data to make it Power BI ready. And we do that here in Power BI's inbuilt Power Query Editor. So when you first bring the data in, everything is recorded here in this specific list. So we need to convert it to a table. And then expand this column. And these are all the data items that we have brought in from the ESPEN portal. So you can choose which of these you now wish to work with, but for the purpose of this demo, let's just bring in all of them. But what I will do is remove this tick box for use original column name as prefix, as otherwise it tends to name all as column 1, SN, column 1, ISO 2, which isn't particularly helpful. So this is all the data that we then brought in from the ESPEN portal. So Power Query Editor has great functionality, and it's quite simple to run and understand. I'm going to demonstrate to you just one data cleaning process, but there are a number of different data cleaning updates that you will need to run here to effectively prep your data set. So I'm going to show you here how to unpivot your data. So what do I mean by that? Well, you'll notice that the forecast data is organized into specific columns for MDA activities in 2020, 2021, 2022, with each row as a separate implementation unit. So this configuration is perfectly logical in terms of the forecast data set, but it's not the best format by which to build a data visualization. What we really want to have is one field or column for year, with the data for each year per implementation unit, then in a separate row. So we need to unpivot our columns for year into rows. It sounds complicated, but it's actually really easy to do. So first, we just need to select which columns we wish to. Apologies, let me just try that again. There we go. Then we need to click Transform and then Unpivot Columns. And you'll see it has done it already. It's that simple. Now, there are a lot of other updates we then need to make. For example, we'll need to rename column headings since attribute and value are not particularly useful. We want to replace any blank values with null values. We want to ensure that each column is set to the appropriate data type. We may also want to join this MDA forecast data to other API calls from the ESPEN portal. For example, the scheduling of disease-specific assessments. So we can build visualizations that take both of these data items into account. Or perhaps we have other data sets in Excel that we also want to bring in. As long as there is a commonality between these data sets, such as a unique ID, then Power Query will help you to do this. So there is a fair amount of preparatory work that needs to be done. But there's a lot of guidance online that will help you to do this. So imagine that we've now done all our preparatory work. So we are now at the fun part, which is building our dynamic visual dashboard. So we're going to be building our dashboard here in this blank space. Here are the various types of visuals that we can employ. And there are others that we can download also. So many of these are quite specialist or they're quite gimmicky, but we do have available all the common best practice visuals at our easy disposal. So we can draw bar charts, line charts, scatter plots, and we can do some basic maps also. Here in this fields list is our list of clean data items that are ready for us to work with. So what we're going to draw up is a line chart. So let's just make that a bit bigger. And our line chart is going to look at the number of implementation units conducting an MDA each year over time. And we're going to plot that against the number where a DSA is scheduled. So selecting our line chart, we're going to drag and drop the relevant fields here into our visualization builder. So let's first take year and drop that into axis. Then we'll drop in our values for MDA into values. And you'll see what we've got here is the count of implementation units conducting MDA by year. So in 2020, 1,777. And as per the current forecast, there will then be 58 in 2027. And we'll do the same also for our DSAs. So the line chart is set to a default look. So now you will then want to make the visual a little bit more your own. And you can do that here in the formatting menu. So for example, you can remove the legend if you wanted to. You can choose to switch on your axis titles. You can change your data colors. There is a default palette, but if you know the hex code of a specific color shade, you can select this also, and so on. There is a lot you can do with this to edit it and make this dashboard really your own. One more. So let's add a data matrix. So a user can see both the graph and also the raw data behind it. So this time, our columns will be our years. Oops. Our rows will be all our countries. And for our data values, again, let's choose MDA and DSA. That looks a little bit odd. So let's choose to change this from first MDA to a count for each. And there we go. That's a little bit more useful. So we have count of implementation units conducted MDA and DSA by country by year. So a very basic LF forecast dashboard, and because our data is all related, so we can already interact with the visuals. So I can choose a specific country, so for example, Coke. And the line chart will then focus onto data just for that country, which is pretty great. So by following this basic example as a starting point, you can create very detailed, dynamic, and effective dashboards, such as this one here. So this is Sightsavers LF Elimination Station, which uses exactly the same processes which I've just run through, but it also brings in some other internal organizational data sets, which will allow me to build up these other visuals. So I'll leave you by saying that if you do want to create a dashboard, it's not a difficult process, and there is a lot of great advice available on the ESPEN API website and in building a great dashboard in Power BI more generally. And if you'd like to hear more about this specific dashboard, the Elimination Station, then do come to the COR-NTD Innovation Lab, where I have a short video to talk you through it, and I'll be there to answer also any questions via the chat. Thank you.
Great. So hopefully you found that video interesting. I see we're running a little bit behind. So if it's okay with everyone, we'll go ahead and go into the break. If you have any questions about any of the prior presentations, please post them in the chat and we'll get to them. But during the break, which will be 10 minutes, we'll have a kind of looping presentation that will go over the Ascend Learning and Innovation Fund. They're entering their second round of accepting proposals. There'll be representatives from the fund who will be in the chat. Kristen will be in the chat. And the slideshow will be looping. So if you want to just maybe consume the data without asking any questions, you'll be able to see the slideshow. But feel free to take the full 10-minute break, and we'll start up about quarter after the hour and finish with our last two sessions. So thank you everyone for your participation, and please enjoy your 10-minute break.
Thanks, Alex, for introducing. And if it's fine, I'll just take up some words, and whoever wants to listen to stays in, and the rest can take the break to maybe answer some questions up front on the fund. So hi everyone to the round, and thanks Alex again for giving me this slot today. My name is Ina, and I'm the fund manager of the Ascend Learning and Innovation Fund, which is funded by the FCDO. And I'm here today to tell you briefly about what the fund in general is doing, and about maybe potential opportunities for you or your network as we're entering the cycle 2, as Alex just mentioned, of our funding. So we're excited to announce that we're giving out a cycle 2 of grants. The general goal of our fund is to accelerate the control and elimination efforts for up to 5 NTDs. And we as a fund, as we are a learning and innovation fund, we strongly believe that the fight against NTDs requires investments in new evidence-based ideas. So in order to achieve this goal, we're now looking for new projects with innovative ideas to tackle problems that we can fund. So maybe important to note here is that innovation in that context is not just high-tech new solutions. that are brand new, but also we're looking for developing and testing creative solutions. We're looking for adaptations to existing things, to new learnings, with a focus as well on, we want to support a vision of scalability with this. So that's a really important aspect when funding projects. What do we provide for you? The fund in general is providing grants between 25,000 and 350,000 pounds to support a flexible range actually of NTD focused activities. So the innovations or the ideas can be reaching from research to large scale implementation projects. We had everything in there in our first round, and we are focused across 13 countries in West and Central Africa. There's more detail on our fund website, and you should see the link on one of the slides and can check that out if your idea or your network's idea could be eligible for it. So in order to progress forward, as I already mentioned, we're now having our application window open, which is closing actually next week, Friday. So there's roughly one more week to go, November 6th. And the fund in general is open to a range of different organizations, as mentioned. There's 5 challenge statements on the website as well. So if your network's idea is falling within one of those challenge statements, we're happy to hear more about it. Also, if you have questions, just reach out. There's also an email provided on the slide. And just visit the website. There's a lot more information on the application process as well, and on eligibility for applications that we receive. With this, I already say thank you for listening and checking out the slides, the website, and reaching out to us via email. I'm happy to answer some more questions here in the chat, and we'll be with you for the rest of the break. Thank you.
Okay, everyone, as promised, it's 1:15, so we'll go ahead and resume. Hopefully you've had a nice break and have been able to rejoin us, and hopefully you've been able to engage with Kristen about the fund, if that was something of interest. Okay, so as we discussed, we're going to shift a little bit from global systems to national systems. I'm going to go ahead and turn it over to our first speaker to talk about inventory tracking. So Benjamin, over to you.
Thank you, everyone. Good morning, good afternoon. For those who are in the eastern side, like myself, thanks for this invite. And I'm going to be presenting with TJ, who is with Standard Co. My name is Benjamin Ongeri. I'm with Crown Agents on the Ascend East and Southern Africa, based in Nairobi. Next slide. So this work was a collaborative effort between ourselves and the Ministry of Health in Kenya, Merck Group, who are the pharma company that donates praziquantel, and we as Crown Agents, my colleagues Tina Patel and Charlie Reeves, thought about this way of trying to get increased visibility of data at subnational level, and we are funded by the UK government on this Ascend program. So the idea was that we needed to build a sustainable and lightweight subnational inventory, I would say, tracking system, and we're going to use tools that are already familiar. So we are not completely getting away from global systems, but we're trying to integrate with those global systems. So some of you, there's no question on this, but some of you may be familiar with NT-Deliver, which thanks to the poll, we now know that we need to explain that it's a post-first mile part of the supply chain, and first mile really refers to those upstream or the supranational part of the supply chain above the national level. So we're talking about, the orders that come from the country and go to the WHO, for example, regional office, then they go to WHO headquarters, they go to the pharma companies that are based, in other continents, for example. Then there's a lot of coordination that needs to happen for the medicines to then be shipped into the country. So that process that happens above the nation is the first mile part, and the last mile is what happens within the country after the medicines leave the central medical stores, going downwards. With that quick intro, so our idea was to really build a system that can show the full life cycle of the medicines from request all the way to the distribution and the inventory, basically focusing on the inventory part of it. Next slide. We really deployed this tool in 2 counties in Kenya. Kenya has about 47 counties. Those 2 counties are in the western part of Kenya, the blue area there, which has been shown in a square. And these are Homa Bay and Migori counties. Each of these counties has 8 sub-counties. And a sub-county can be seen, is really a district. Maybe that's another word for it or another name for it. And we wanted to focus really at that sub-county level because we believe that the information that we need for decision-making, what we get at that sub-county level is sufficient, at least for the supply chain perspective. The subject drug that we focused on was praziquantel, but the tool was built such that it could collect data from any medicine for that matter. And we wanted to make it really simple. So next slide. So how did we go about this? TJ will get into the mechanics of all this, but we wanted to have a communication medium. I remember Alex mentioned that it's SMS based. I wanted to just correct that. There was an earlier pilot that had been done by Mark in Kenya, which was SMS based, and I'll let TJ maybe talk a little about some of the limitations which we're trying to get over by using, by going through this new platform, either via via WhatsApp or via email. So we worked with the MOH to get a list of, the county coordinators and pharmacists, their contacts, and then gave them a brief online session to just understand what we're trying to do and send through the survey. And TJ will talk of what we were able to get out of it. Thank you.
And thank you, Benjamin. And my name is TJ Muehlman. I'm with Standard Co. And I'm going to talk a little bit about the technical implementation and how it's relevant to the discussion that we had earlier this morning or this afternoon, and using various integration hooks. But really quickly, I want to kind of give a little bit of background. As Benjamin mentioned, we helped run a pilot in Kenya over the last several years using SMS to collect data on the NT Deliver platform. And one challenge that we had with that one is because that was school-based and because it was over 2,000 schools that was deployed in, and SMS is an unstructured data medium, it was difficult to kind of collect good, clean data. And so this new pilot, or I shouldn't call it a pilot implementation, really sought to correct that problem by moving away from the school-based data collection activity to the district level data collection. And we wanted to really use sort of, as we mentioned, familiar and existing tools. So this was built into NT Deliver, which already has the first mile data, which is batches, quantities, and expiry dates, and when they were shipped to the country. And that data allowed us to kind of pre-populate a lot of the data that would otherwise need to be collected. So it really boiled down to a very simple web-based form that people could fill out on a smartphone or on a desktop, and simply provide, is there medicine left over? how many bottles do you have, and select the batch. So we're now kind of marrying these two things together. The first mile, which is shipment data from the donor, to the last mile, which is what is actually in the district pharmacy, what is actually in the medical store, what has actually been used. And to the best of our knowledge, this is one of the first times we've been able to kind of roll that kind of data up. It also syncs with a tool we call the expiry report, which helps monitor batches that are going to expire. So now we have this system that kind of leverages data from a variety of sources, and we'll use that data to build a dashboard. And similar to the dashboard that Andy presented from Sightsavers this morning, we have our own dashboarding tool that is very different than the one they use, but it leverages the same concepts. It uses the ESPEN APIs to get JRF and JRSM data. It uses APIs from NT-Deliver to understand how many tablets were actually sent to Kenya. It leverages data import tools from KEMSA, which is the distribution authority in Kenya, to pull in how much was shipped once it reached Kenya, how much was distributed to the district. And last but not least, the data actually collected from the districts themselves. So this dashboard is, kind of brings together a lot of the themes that we've heard so far, which is data integration and unifying this data. So a lot of the data on the screen that you see here is actually not data that's housed in NT-Deliver. The maps are built from ESPEN, the distribution data from KEMSA, and the JRF and JRSM data comes from KEMSA, or comes from ESPEN as well. And again, building all of this, it allows us to kind of centralize a lot of this data. So I think that the last kind of natural discussion is, well, what do you use that data for? What's the ultimate goal now that that data has been collected? Well, you know, one thing that we do is we sit on this NTD supply chain forum, and we frequently discuss inventory. What do countries have on hand? What is available? And we recognize the difficulty in collecting that data. So providing a very simple tool that doesn't require a lot of training and doesn't require a lot of upfront cost allows us to deploy or offer the ability to collect this data so that it can really kind of be, three things could be done with it. One, integrate the data back up to the national LMIS system, which is something we will be discussing with KEMSA. Two, integrate that with the regional WHO system, and in this case, that would be ESPEN. So ESPEN obviously is the primary data hub for ESPEN countries in the Afro region, and there's opportunity to kind of share this data with the supply chain team at ESPEN. And last but not least, the global supply chain systems, which is NT-Deliver. All of these three kind of pillars would allow us to share the same single data points with multiple systems so that the data is unified across all of these platforms, and ultimately saving people a lot of manual effort and getting better quality data to people. That's our presentation.
Great, thanks, TJ and Benjamin. So I'm going to go ahead and pass this on to Caleb, who's going to talk a little bit about his work in Nigeria with integrating TT surgery with eye health. Caleb?
Okay, so in the context of implementing trachoma programs, the first thing is that once we go into implementation, it's either a community-based sort of provide community-based surgery through outreach, or we provide facility-based surgery, which is usually done. Next slide, please, Sarah. When we have outreach-based surgery, this is usually done when we have not reached elimination for trachoma. And so it involves house-to-house case finding, and then surgeries are provided as close to people's home state as possible, because we realize that if you have to wait for people to walk up to facilities to get surgery, many people are not reached. So if you want to reach as many people as possible, then you have to go out there and reach them. But once you reach elimination, that means that you have very few people who need surgery, So you then move on to facility-based surgery, where you then provide, allow people to walk into your health facility and they get treated for their surgery. Now, most of outreach-based surgery is done through the NTD program, while facility-based surgery are actually done through the eye care system. Very often, once elimination is reached, of course, the NTD program, funding for NTD or TT surgery through the NTD program usually ceases. Next slide, please, Sarah. Yeah, so in Nigeria, the TT program is mainly implemented under the NTD department. In some other countries, we are aware that the TT program is done under the eye care program. Now, as I said, they are community-based because you need to reach those who need the surgery and are usually far removed from health facilities. So you treat them based on that. Now, so data that is aggregated on TT surgeries, usually you have them, the persons operated are registered in the health facility. The names are there in the registers of the health facility, but the transmission of data is usually done through the NTD program. There is hardly anything happening through the eye care program. And indeed, through the NTD program, electronic data transmission is being undertaken using the TT tracker, which is a COM-care-based application that assists surgeons and indeed managers in tracking the number of surgeries done, where they were done, and also the outcome when follow-up is done. Thank you. Next slide. So when do you move from an outreach-based sort of surgery to facility-based surgery? You would have reached TT elimination. And WHO says you would have reached TT elimination when the prevalence of trachomatis unknown to the health system in persons 15 years and above is less than 0.2% in a formerly endemic district. But you also need to provide evidence that the health system can identify and manage incident cases using defined strategies. And then you show evidence that you can finance that. And I think that's where we have a lot of problems. While it is an outreach-based program, the NTD programs support it. But once you move from, you reach elimination, you are moving on to facility-based surgery, there's a problem with who supports the surgery at that point. And a number of the eye care programs will charge money, a user fee for surgeries, while many of the people that need the surgery cannot afford that. So this becomes challenging because it's a requirement for the to show if you are when you begin to apply for a validation of elimination of TT. So there's therefore we think that at this point that investment should be considered to build partnerships right from the beginning, so that you can see how once funding is gone, people can still access surgery even when they cannot afford to pay for user fees. Next slide, please. Okay, so you then begin to transit when you do an impact survey or a surveillance survey or a TT only survey, and you show that you have reached elimination, as we've discussed earlier. So you cease dedicated case finding, and also you discontinue outreach surgeries. Now, TT management services for incident cases and any remaining cases will be provided through routine eye care services. And you need to also show reporting of those cases. Now, when they were being implemented as outreach, it's easy to have the records being transmitted through the health system because the NTD program needs to show information on what is happening. But once it transits into a facility-based surgery, it becomes very sticky because the eye care program doesn't have that system of transmission. Even with the district health information system, TT surgeries are not captured already in that system. Next slide, please. So this brings us to the challenges that we face. And the first, of course, is that TT surgery programs are implemented and reported under the NTD department. And once you reach elimination, and NTD programs transit, routine facility-based surgery is done under the eye care program. So, and then we do not have reporting templates and a structure for TT surgery data under the eye care program. You may find a big column under the DHIS for just eye diseases, or at best, you may have a column for cataract surgeries. But for TT surgery specifically, you do not have that. So you find TT programs struggle to show that they have evidence that they are managing TT cases even after elimination has been reached, because they cannot show how the numbers that are being done, because there's no reporting system under the eye care program for the number of TT surgeries that are being done. Next slide, please. So where are we now as far as this situation is concerned in Nigeria? There are a number of districts where we have reached elimination for trichiasis. And so they have transitioned. That means TT surgeries are now being provided by the eye care units and, of course, by eye care personnel. Now, the TT surgery data is available at the health facility because every surgery that is done is being reported, is being entered into the theater register to show that persons have been operated on. However, the reporting is still done through the NTD program. The eye care, so in essence, the eye care program has taken ownership of providing TT surgery, but it doesn't have ownership or doesn't have a system to report the surgeries that are being done. So because we were faced with this problem, and we think that the eye care program should take absolute ownership of the TT program as it is, we've had to enter high-level discussions both between the NTD program and the eye care program to ensure that there's a system of reporting for the number of surgeries that are TT surgeries that are being done within the eye care program, just as they are providing the service itself. And we're finding a lot of difficulty in changing the DHIS system to capture that, simply because initially, eye care programs actually provided TT surgeries, but they sat down and waited for patients to walk into eye care facilities. This did not meet the needs of what we thought should be done under the NTD program. So it was easy to transfer TT surgeries under NTD programs because it was going to get better funding, and therefore more people are reached with surgery. So there's no provision for that. So one of the high-level discussions we are having is to provide within the DHIS system a line for reporting TT surgeries along with other eye care parameters that are being reported in the DHIS system. So this is where we are in districts where transitioning has taken place. Next slide, please. In districts where transitioning has not taken place, which means that a lot of community-based surgeries are still being provided, we are looking at how best to begin at this point, even before transitioning, to capture this data also within the DHIS system, so that eye care programs take ownership even before reaching elimination of not only the service provision and the personnel, but also take ownership of the data reporting system so that we have a system, a data reporting system that is integrated into the eye care system. Next slide, please. And I think that should be the last slide. So we're asking then how best can we get this data transmitted move from a NTD vertical routine into a routine hospital records reporting system. And we think that if we begin to consider strategies of transiting from disease vertical programming into integrated programs, it can be seamless when we look at the fact that we can integrate the outreach. Even when we're doing outreach services, we can always use facilities, and therefore the data can be captured at the facility level and is still transmitted both through the NTD program and also the HMIS or the DHIS system as it is. Because already we have virtually all the surgeons that are providing TT, so they're actually eye care personnel. So it's not going to be introducing any new records for them to be entering. They will definitely have all the records of TT surgeries they have done, and all that they need to do is to have a template that they can report the numbers they have been doing. We also think that we can develop local capacity of the various health institutions to be able to see that TT surgeries services are an integral part of eye health, and indeed it is. And so they should be able to see that it's important to report all that they are doing, including TT surgeries, so that the system can have a seamless way of reporting. And we think that we can also encourage eye care departments to develop a more robust data reporting template and to include trachoma data, which would actually involve the number of active cases they are still seeing, apart from also having the TT surgeries that are being done. These are our thoughts at the moment as to how best we can push this forward. And we think that we could learn from many of you also how best we can push this forward and make sure that we integrate the data reporting for TT surgeries into our routine eye health systems. Thank you very much.
Thanks, Caleb. No, it's a great presentation. You know, this theme of alignment of NTDs with national health systems is going to come up later in our very last section, where we have very short breakout groups and discuss various questions about some of the challenges and opportunities of aligning these NTD programs, which have really run as disease vertical programs, with national health systems. You know, that can be a challenge because the partnerships and the capacities aren't really developed within the national health information system in order to facilitate that integration. So transitioning can be a challenge. So Elena, I know you're kind of doing double duty with presentations. Are you still available to present?
Yes, I'm here. Can you hear me okay, Alex?
Excellent. Yes.
Awesome. Well, I'm impressed. It seems like we have a pretty good group of people who are familiar with statistics. And I'll say I myself was not, a statistician by any means before I started my doctoral program, but it's great to see some people have a foundation already. So kicking off with our theme here, to just allude to what Alex, you had noted in the intro, you know, we can invest in all the data we want, right? But at the end of the day, impact is key. So what is the data actually influencing in the process? What kind of positive outcomes or negative outcomes are we seeing as a result of what we're investing in? And this is very much the theme of our study. So presenting on behalf of us, as well as some of my fellow researchers from the University of Bath and Trinity College, we looked at the impact of the NTD Deliver system specifically and wanted to understand, did it have a significant impact, especially positive, on the performance of the first mile of the NTD preventative chemotherapy donation supply chain. So I will also be presenting this as well at ASTMH. So I'm going to give a little bit of a high level view and focus more on the results a little bit for those of you who are also attending ASTMH. But just a little bit of context too, because I did see in the results earlier from the poll that first mile is a little foreign to everyone. So the first mile of the supply chain, when we're talking about that, focusing on that, we're really focusing to the point of delivery of the donated medications to central medical stores. And the NTD Supply Chain Forum is a group that, especially was originally put together to focus on that. I know they've since expanded a little bit of their scope to also consider last mile, but that's the scope of the research that we did. So as you know, some of you are familiar with, and the scope of the presentation earlier was focused on NTD Deliver. A great tool was launched in 2016, originated by the NTD Supply Chain Forum to look at integrated data in the supply chain on the shipment tracking in this first mile. And so the open question that we wanted to investigate, well, what has been the impact of this tool? And specifically divided into two research questions. What is the impact generally on the shipment performance? And secondary, and very importantly, I think especially to the focus of this group in this session, is what is the impact of the performance once that information sharing was extended to a publicly accessible audience? So a couple years after the system was originally launched, there was also a publicly facing dashboard and data that was released. And so we wanted to look at that as well too and see if that changed what we saw in the impact. Again, seeing first if there was any impact to begin with. So a little bit about the design, high level. Again, don't want to bog everyone down in the details, especially as I'll be going through this a little bit in ASTMH. But essentially what we did was what we call a quasi-experiment design setup, which sounds less impressive than it is. But basically what it is it lacks an absence, there's an absence of a randomized control group because we're doing this research in a real environment, practical setting. And so the way that we designed this research study was we took, the great thing about NTD Deliver was that it had the historical data of the shipment performance before the system was actually implemented. So we split the data into the groups of data that was in the system, and that was, being tracked before this NTD Deliver system was implemented, and then after. And we took, of course, because this is, doesn't have a randomized control group, we took many control variables into account to help protect the validity of the results. So controlling for the WHO region, controlling for disease and medicine, because we know there's many factors that can also impact performance. We wanted to have more certainty that the NTD Deliver system was the cause for the observed results that we would see. So the scope focused on pulling data that was from as far back as 2006 till the end of 2018. So that covered a good amount of shipments. We did a quantitative analysis, linear regression, as some of you are familiar with. And so that's the results that we'll be presenting, but I'll take it, I'll try to present in a way that a lay audience can understand the results as well too. So for those of you who are less familiar, don't worry. Before I get to the results, just as well context, to help with the understanding the interpretation, we had a number of KPIs that we looked at as our dependent variables to assess the impact of performance of the system. And for the group's knowledge, the way that those KPIs are calculated impacts our interpretation of the results, specifically the coefficient. So for some, a positive coefficient might indicate an improvement. For others, a negative coefficient might indicate improvement. It just depends on how that KPI is calculated. So starting with the first set of results that was oriented around our primary research question, again, did this system overall have an impact on performance, since it was implemented? We found some very, interesting and significant results, specifically 4 variables that were in scope of our study showed a significant impact as a result of the system being implemented. The good news is 3 of them showed a significant positive impact, and particularly delivery timeliness, which we're defining as delivery to the central medical stores, because we're looking at the first mile, had a significant positive impact. So arguably this is our most important variable, right? Because this is really the end of our supply chain. POD timeliness is a little bit more of a paperwork type of a process, so that's why delivery is most important. And as well, also interestingly, PO issue timeliness, also a very important indicator, observed a significant and positive impact. Go signal timeliness, as you see, and that's why this is in red, had a significant negative impact. We explore this a little bit more in our paper, which we're working on as well, submitting for publication by the end of the year. But there's a little bit more nuance to this one as well too, which helps explain the results. But a couple things just for the group to understand. One was the level of visibility for the initial data, and those involved in the go signal timeliness process. There's more than just the actual actors that are managing the first mile of the supply chain in order to gather the needed documentation for go signal. So we theorize that because the transparency was extended later, maybe some of those individuals that are involved in that gathering process weren't as familiar with this data being released. That could explain some of that. But as well, the other interesting thing we observed is that actually the requested approval date did significantly move up earlier after the system was implemented, meaning that the standard was raised. So that was an interesting thing to think about too, that even if it seems to be underperforming, the standard for timeliness has appeared to also been raised. So that gives a little more nuance to that result. Now, this is where it gets even more interesting. I think this is kind of a great takeaway for this group. But as I mentioned, our secondary question was looking at what has been the impact of the publicly accessible data? Has that made a different impact? And what we did here, a little bit different in the design was instead of splitting just the pre-NTD deliver system, the post-NTD deliver system, we just looked at the data, that was relevant to the post group, and we split it against the number of data that was involved since those publicly accessible pages were implemented to compare the performance against itself. And what we saw, as you see here, is very significant positive improvement for 3 downstream indicators: shipment, arrival, and delivery. The coefficients being, compared to the previous result, even higher, and in this case, more impactful, we can say for these indicators. So that appears to, have some very great implications for the level of impact that we have when we make data more transparent. In this case, of course. So thinking about the implications, thinking about the summary of these, these results and the takeaways. So overall, the exception of go signal timeliness, for those where we see that significant impact, it's positive. So we can say that investing in this kind of data and performance tracking has an overall positive impact. But as well, extending that information sharing to a publicly accessible audience has an even greater impact, especially, on those downstream most important indicators. So something to think about, is, does transparency, does it have this impact in all cases? Of course, we can't necessarily generalize. We need to explore that further. And as well, I think we need to better understand too the how of how the data is used. So there's multiple supply chains, multiple partners, in this group of data. Will the impact be greater if their data is reviewed more often, or if it's reviewed in a certain way? So we did not necessarily explore the how of how the data was used, but I think that there's opportunity to do that. And of course, a huge thank you to the NTD Supply Chain Forum. They generously provided access to us to the data used in this research. We hope it generates a lot of great discussion and thought for how we can kind of think about data and integration and impact in the wider community.
Great, thanks, Elena. All right, so I realize that we're sort of over time at this point, and I know people have lots of various meetings they need to attend. We did have one additional section that I wanted to go through with you, and those of you who are able to stay or able to do this on your own, I would greatly encourage you to do so. And I'm going to put a link in the chat that I'd like people to just sort of take a look at, and I'll share my screen so you can see what it is that I just shared. So there's this tool called Fun Retro. If you go to the link that I shared, you'll be able to see 4 questions. And under those questions, you can click this plus, and it allows you to add a card. And that would be basically an idea that's related to this question. I don't think we need to go through this as a group. I understand we're already 20 minutes over time, but please, feel free to use the link. feel free to add your own ideas into this fun retro board. I think it's really helpful. You know, I think these 4 questions represent a lot of the topics that we've talked about today kind of rolled up into a discussion point. You know, the first one would be, if data demand and use is the goal, is it possible that existing MOH teams, which are comprised of disease focal experts, M&E staff, can take on additional data analysis and data system integration efforts? Or are new staff with new skills, do they need to be added? You know, we talk about the opportunities of these data systems, but, you know, in order to be able to take advantage of those opportunities, and it is possible that some task shifting could occur, are existing staff able to task shift into those new skills? Often you find that there isn't a lot of slack capacity at the Ministry of Health. So that could definitely be a challenge. And just because you have increased access to data, there's not a linear association with use. So I think that's kind of an interesting discussion point about, you know, do we need to have that consideration when talking about these systems? And you can go on and read the other questions on your own. So I think I'll stop there. I'll just thank everyone, all of the speakers, for their time and their effort in putting together these presentations. All of those that are attending, you know, thank you very much for listening attentively, and hopefully you were able to take something away from this. You know, please reach out if you have any questions that weren't able to be addressed during the chat. I know that a lot of comments were addressed during the chat, during the sessions. And again, thank you so much for your time, and we'll go ahead and end the session here. And thank you so much.